No decisions today, but this is my favorite meeting of the year.
We need to make a decision on a
Oh, that's right, the
chair and vice chair.
chair, although that could be forced to delay if needed, but
Yeah.
This is the one that I think everybody should be at. Give it just another minute or two. Robert's joined. I know Kimberly cannot join. So, a lot of people jumping in right now. So we got Robert and me. And we do have 3 of 6.
We just need one more.
Yeah.
Dr. Laura is here.
Okay. So we do have 4, although 3 are OEB, right? Any news from Greg?
I haven't heard anything from Greg.
Because he's the only one, because we already know Kimberly can't make it, right? However, we do have enough to get going, so we might not be able to do the. No, I guess we can. We got enough.
Yeah.
All right. So let's get started. Let me call to order. By the way, let me just announce that Kimberly Hendricks, our chair, cannot make it today. So I am going to run the meeting, me being Bill Gropp, and call to order this meeting of the SEOW board, SEOW work group on this Tuesday, June 2nd. Time is 9:02. I show 4 members present: Andrea Foltz, Robert Young, Dr. Laura, and myself currently, with Greg maybe joining later. So we do have 4 out of 6. We're good for that. Now I'll go to the members and say, did everybody look at the meeting synopsis for May? Any comments on the meeting synopsis for May? If not, I'll take a motion to adopt the meeting notes for May as presented.
This is Andy. I'll make a motion to adopt the main notes as presented.
Robert, second.
All right. Any discussion? If not, I'll take a vote. All in favor of the motion, please say aye. Aye.
Aye.
Right, 2 people made the motion, so we're good, unanimous there. So we're moving on now to our presentation. I guess it's Mercer, but it's going to be a whole lot of Mercer, like I assume, for the Health Innovation Report. So I'm not sure who's kicking it off, and then Dr. Chuang is going to kick us off. Sorry, my cat is bugging me, if you can hear my cat.
Thank you, Bill. Yeah, today we've got a list of topics that we've selected for more of a discussion, informative discussion under the context of innovation. The focus that we are taking here is innovation that's sort of close to reality or emerging into our reality in terms of utilization, clinical utilization, and relevance, as well as plan coverage. And then one area of just challenging our mindset, thinking be outside of the box being the structure of our U.S. healthcare system, because some of the things that we aspire to do to achieve on behalf of the members, the educators that we support, is somewhat constrained because of the system we find ourselves. So just, again, under the context of innovation, I think we took a little leeway to say, imagine if we could do something different, and what could that look like, and how is that possible? Obviously, there are process and compliance and other things, but I just wanted to highlight that some of these barriers can be overcome if we're thinking outside the box. This should be interactive. We've got slides. I will provide context. I will inform, but again, happy to take questions. And to the extent that I am not expert on these, I know about them. I've been tracking them. I can speak to it, but Bill, don't challenge me too hard on the technical functionalities. So we're going to go over these things: artificial intelligence, which is quite broad, and we're going to look at it in terms of the evolving trends and patterns. The category of omics, which is sort of a short form for things that we can now measure that have labels, whether it's genomics, so the study of genetics, to metabolomics, metabolites and metabolism. So there's some categories here to go over. Where we can sort of get the most bang relative to what I consider innovation, right? Sometimes innovation sounds good, but it's impacting a small number selectively, as opposed to thinking of innovation as the ability to really impact where it's necessary at a larger scale. Looking at seeking care that is difficult or expensive in the US, outside the US, what that could look like. And then we'll go into pharmacy landscape, because obviously there are a lot of moving parts and pieces there. So that's what we'll go through. Next slide. So in diving into AI, what I'll say is I've included visual graphics from the sources of information. The way it's laid out is very sort of usable, useful. So I'm asking for sort of pardon for some of the potentially smaller fonts, but the structure of this is kind of useful to use and facilitate the discussion we're having today. So if we look at the chart on the right side here, this nicely lays out a timeline of where we're seeing AI-based technology coming into the healthcare delivery system. And the first one is interesting because it is near, it is now. It is really around chronic disease management, right? So it is digital support apps, inclusive of technology capabilities, including AI, that basically can now support individuals around chronic disease management. Because the reality is the medical care model is really sort of a fragmented point in time, short time frame, right? 10 minutes, 15-minute office visit to cover a complex chronic condition that is being addressed. And ultimately, it's what the individual needs to do or is doing between office visits that is equally impactful, as well as the diagnosis and the medication that gets prescribed during the office visit. So that is happening now, and it's expanding in terms of the kinds of conditions through commercial point solutions to support them. The next one has come up a few times in different conversations. It's the image-based diagnostics. Images at the heart are pixels, right? Shades of black and white, shades of gray to potentially in some colors, but requiring human visual interpretation and processing isn't always consistently consistent. And we may miss, signals that are buried within all of that pixelation. So leveraging AI and technology is being applied and is slowly becoming more commonly used. And I'll go into ways in which that is being taken advantage of. Oncology is the next area, again, because oncology is evolving so quickly. What we do know now is a specific organ cancer is not just one type of cancer. Breast cancer is not just one type of cancer. It is many, many subtypes. And a lot of that determinations of the type is genetically based. And the kinds of treatments that we can personalize are now multifactorial. So it's not just based on a pathology, it's pathology, histology, genetics, etc. So when we're having multiple data needed to be factored into decisions and treatment protocols, leveraging technology, big data, and things like that is where that can add value and augment the clinician in terms of the oncology care. The other areas further out in the future is going to be around conditions that are somewhat complex because of how they are defined, how the body sort of develops these conditions, and how treatment options are available. So again, it comes down to many factors, many branches in the decision making that lends itself to leveraging technology and AI to mine through robust sets of data and to be able to more make recommendations and guide treatment in a more precise way. The last area, which is really out in the future, is really around more robotics. It's automation and sort of no longer requiring human guidance, but more autonomously. And we're talking about procedures and surgeries. Right now, when we're thinking about robot assisted or augmented surgeries, it really is an extension of the human extremities is what we're doing. So if it's minimally invasive surgery, we're using instruments that extend beyond the hands, take up less space, and we can do it through small holes, but it's really an extension of human extremities. Potentially, it can be all automated, and through complex logic and visualization, surgeries can be done in a more automated way. That increases capacity, throughput, and things like that. So what remains for the physician from a care perspective is going to be where, at the end of it, all this information and feedback from AI is helpful, but it's a joint decision, right? So just because the treatment is available doesn't mean that's the right treatment for that individual. That individual has a say, and it's going to always be a person-to-person conversation, translation, and guidance of treatment that's going to be key, and the opportunity for physicians. Bill, you have a question?
Yeah, just this is a curiosity question, not a push. Just any work that you know of in AI and immune system disorders?
So immune system is also, we know now, tied to genetics quite a bit, and not just genetics, but also the whole cascade of the omics. So many things stem from inflammatory biochemical processes is what we know now. That's inclusive of cancer, allergies, autoimmune conditions, etc. So yeah, when you ask about autoimmune, I think of it more the biggest bucket possible, not just the autoimmune diagnosis or diseases like psoriasis or things like that we think about, but because those are very precise treatments. They are expensive, but they're precise. I believe that there'll be more and more biologics, right? Biologics are basically treatments developed through living organisms. So to do that is complex, and you really have to get to that level of precision. And that really requires assistance, whether it's big data analysis or figuring out the biochemical manufacturing process to get to those kind of biologics. So the point I'm going to make on the side is, on one hand, medical care is going to go through an evolution where AI initially augments the care, but at the patient person level, we also know that there's a lot of things that we need to do outside of the four walls of a hospital system that can be guided, supported, enabled through AI-based solutions and apps. So those are now sort of the two definitive branches. And in a way, what we're seeing at OEB and PEB, looking at the point solutions and what we can do beyond traditional medical care is reflective of this first category, which is to acknowledge that many things we can't just prescribe our way out of. It is about individual choices and behaviors and supporting them in making those changes. Next slide. So if we agree that is true, then how health benefit package starts to look like is kind of the following. I think historically, the focus has been around illness and disease care within the medical system. I simplified the journey of the individual really comes down to a patient requesting care or seeking care. And within the office visit or the hospital care, it is about assessing, diagnosing, and treatment. And to a large extent, outpatient treatment is mostly prescribing. And then we think we're done, and then we wait for the patient to come back and say, I need more care, right? So we're basically making the case that with AI and digital capabilities, advancements, we can now surround the medical disease illness care with a more robust health focused set of capabilities, starting with screening and prevention, primary and secondary. So primary prevention is in the absence of the disease. Secondary prevention is knowing that you are at risk, we're going to try to prevent. And then tertiary or third level prevention is in the presence of disease, how do we prevent it from getting worse, right? All of that is partly based on medical care, but a lot of it falls outside in terms of what individuals need to do, think, and plan and optimize for their own health and well-being. So as we go forward, again, the innovation, air quotes here, so to speak, is how to build out that supportive care system that is focused more on the health aspect, keeping somebody from getting ill, minimizing the onset of those diseases and conditions. But when they do need them, there is the medical system that is more illness and disease center in terms of the care. And how do these work together seamlessly for the individual so that their needs are covered across their care continuum? Okay, next slide. So, yes, Bill?
Oh, I was just making the point that I wonder if these in the diagnosis and treatment using AI, if it will mitigate biases that we know occur in treatment decisions in today's system, or whether it will just continue those biases. That's not a question for you. I'm just throwing down that fuel for thought.
Yes, that is always an intrinsic risk, because leveraging big data, it's still predicated on what we know currently, but what we know currently isn't always the absolute truth. And we have systemic biases in terms of research, and that generates the available data that is skewed sometimes. Now, real world data gets interesting, but then real world data isn't always clean. It's kind of messy. So I'm not sure how that will get applied. But yeah, lots to learn still as we evolve. Here I took screenshots from the vendors themselves. So again, this is just an example of digital platforms that takes advantage of big data and AI, but it also focuses on the user experience and the ability to make it flexible, right? So here is an example on the left is an app called Sleep.io, which focuses on supporting individuals to optimize their sleep, what they call sleep hygiene. An interesting label, but it's really optimizing the factors that lead to good restful sleep, sleep that re-energizes and recalibrates the body for the waking hours. So that's one area. These are FDA approved. So, that's one option here. The other one to illustrate here is around general anxiety disorder. It's taking a treatment methodology called CBT, or cognitive-based therapy, which is really sort of talk-based therapy. And people gravitate to these apps because of what we're finding: two things. One, it is accessible in a convenient manner at a time that is convenient for that individual, because it is on a digital app. So it's basically 24/7 availability. So no longer are you constrained to a 9 to 4 therapy session hours at the convenience of the therapist. This is truly given it in the palms of your hand when it's convenient for you. The other advantage is because it's through an app, sometimes we have challenges speaking about sensitive topics or personal experiences that are highly sensitive to others. This kind of creates a sort of a screen that for some people resonates and makes it easier for them to have those conversations in the model of a CBT because they don't feel like they're being vulnerable to a stranger. So the two examples of digital platforms in the space of mental health that is showing good promise. Next slide. So the near-term realities of AI in terms of care across these three sort of stakeholders is what I laid out here. So we have a sense of sort of how real is this? How much of a concern could it be? And what's the potential ramification to a health plan? So on the employer side, we're seeing more interest in carve-outs because we realize that for some of these conditions, individuals need care and support beyond just that office visit or the visit to a healthcare provider. So augmenting and extending the access to support, guidance, and care is looked at as something that is valuable and useful for some of these kinds of specific conditions. From a provider perspective, AI right now is mostly focused on helping them in terms of efficiency. So whether it's documentation, providers use EMRs, which historically is a lot of typing data entry or checkbox clicking. Now with AI, it can do basically very quick speech to text, and that improves their efficiency. They can see more patients. And number two, it actually can improve their billing. So that's some of the impact to the plan because of technology and AI is if they can document better and more, it can translate to more robust coding charges. And we're seeing some of that carry forward into claims cost is what we're seeing. From a clinical care perspective, it is being leveraged to support diagnosis and things like that. But that is sort of lagging behind the benefits from efficiency and medical, legal, and billing optimization. That's sort of the main driver. But over time, we'll see it included in more clinical decision support, which means more precise and correct diagnosis, et cetera, what I highlighted in oncology space and chronic condition space in the previous slide. From a carrier and payer perspective, AI technology is assisting in looking at complex patterns that raise suspicion or concerns around fraud and abuse, assisting with prior authorization automation for efficiency and ease and convenience to the providers and members, and then also member service chatbot. That's kind of where we're seeing the AI being leveraged. So across the three stakeholders, that's kind of where we are at currently in terms of penetration of AI technology and capability. Let me pause there before going to the next section on imaging. Okay, next slide. So AI and imaging is something that's been slowly being researched and now is becoming more systemic. And I listed the two areas where they are being leveraged. One is workflow and prioritization, and the other one is incidental findings, something that's come up in previous meetings. And I'll start with incidental findings, right? So that is the process in which an X-ray or MRI is being ordered for a specific reason. So let's say it's a chest x-ray for possibly pneumonia. But in the process of ordering that chest x-ray, you've got an image of the entire chest. You can potentially find other findings elsewhere that wasn't the reason why you ordered that test. Historically, it would be noted by the radiologist. I, as the physician who ordered it, may or may not pay attention to it. So that was one of the challenges. It's like, okay, I'm just focusing on whether this person has pneumonia. That's why I ordered the x-ray. It's assisting me in my clinical work, and I now have information to guide my treatment decision. Since he's not here for the, other finding, let's say it's a little nodule on the side of the heart. As a physician, should I be addressing that? Possibly, but since they didn't make the appointment for that now, chances are I'm not going to address it here. Ideally, I should remember it and circle back with that individual and say, by the way, we need to follow up on this, but things fall through the crack. And the radiologist may or may not notice that. With AI, images can be run through more systematically. So now we're not relying on the radiologist to use their vision to detect some of these small incidental findings. Now here's the risk and the benefit. Human vision has a sort of certain level of detection capability. With technology and AI, they can detect things much smaller, much more subtle that we would have missed. So now there's this concept called incidental loma, right? So incidental loma basically means it's something that we can identify incidentally, but we don't know what to do with it because it is so sort of small. It's before anybody even knows what to do something about. It's definitely before that person has symptoms and is complaining about it. So that creates a dilemma. We may know something that we don't know what to do about, and wouldn't treat, right? I'm not going to take out a whole lung for something that's 2 pixels wide, but definitely the AI says that 2 pixel wide thing shouldn't be there. Now what do I do? So there's some complexities, and again, areas for research, big data, and things like that. But the intention is that instead of relying on human behavior to look for these things, find them and follow up, AI can help and augment in that process. So that leads to the left side, which is workflow and prioritization. So if x-rays are being done frequently, the radiologist doesn't see the patient. They're just looking at the x-ray image. They're commenting on it. AI can sort of connect the pieces. And it's in addition to identifying incidental findings, they can be more precise, put their findings in context. And then when you have 100 x-rays that have been done and reviewed, instead of the radiologist going 1, 2, 3, 4, 5 sequentially, AI can assist them in prioritizing and say, hey, there are a few things that should be addressed first. So it basically creates an acuity queuing system to help make sure that the important things are addressed first in a timely way, and the follow through and the follow up is done without falling through the cracks. So again, it's the workflow and the prioritization that improves efficiency and obviously member experience and speed to diagnosis and treatment. That is showing to be very beneficial. So the combination of two within the radiology imaging workflow is tremendously of value. And this will also be continuously evolving. We're just at the beginning in terms of what we think this can help with. Okay, so let's go to something that's more novel in the imaging world. Next slide. So this is an example of an FDA-approved image processing device. So apologies if this is somewhat graphical, but the 2 images there are basically for an ulcerative wound. Again, visually, when I look at that, I can see the color difference and I can only interpret it to a certain level of clinical insight, because all I can see are sort of some colors and shades of gray. But buried within that, this device, through looking at a lot of images, correlating those images with eventual diagnosis and outcomes, it can basically start to provide guidance of whether there is some hidden infection in those areas. Right? Ulcers is one of those weird things. You don't have a skin, but it may be just fine, open wound, because it's clean. And then other areas, we're starting to get seeding of the bacteria infection and things like that. So basically, this is through repeated image analysis, it's able to translate and look at a wound and help guide whether there's potential risk for an infection that's invading the skin ulcer. So that's one example of more imaging-based AI capabilities. Next slide. So this is FDA approved. The next one is FDA approved also. This is now what we call brain-computer interface. So this is basically a retinal implant. A microprocessor receiver is implanted in the retinal area, illustrated on the far right there. And it's put in an area where your retina is basically no longer able to respond to light signals and process those signals. So in your brain, it just sees a black spot. So by implanting that there and then putting in front of the eye, basically an image processor that takes things that are visual and transforms it to signals that hits this receiver, and that will process it in a way that sends it to the brain in a way that it understands. So basically, it's mimicking what your cones and rods were doing when it sees images. So it fills in the blank of that space, and you are able to interpret and process that image. So this is for age-related macular degeneration, or also retinitis pigmentosa. So this is just the beginning. Obviously, this is just one use case, and it will expand over time. Next slide. Another area where AI and device is intersecting is around what we call exoskeleton. So these are mechanical, external, movable devices, typically for the lower extremities, for individuals with paralysis or severe lower limb weakness. It basically now can enable somebody who is paralyzed to stand and be mobile to a certain extent, right? They're not about to run a marathon, but they can definitely get up. They can walk, often with still an assist, but they're able to ambulate. The devices can sense body positions and intent, right? So if you're sort of pivoting, you're able to use your upper body to swing the right side of your body, it's going to interpret that you want that right limb to move forward. And it will go through the mechanics of taking that step in a way that holds your body up, keeps you stable, yet allows you to ambulate. Right now, CMS has this as an eligible coverage within Medicare plans. As far as I know, it is not covered in commercial plans as a basic coverage policy. It's considered currently investigational and unproven. The cost on the Medicare side is about $90,000+ for this device. And as a point of reference for the eye implant, that runs around $150,000+ for doing that procedure. That's FDA approved, but it can be covered under what they call sort of exception authorization reasons, but it's very limited in terms of its applicability, whereas probably exoskeleton could be more generally relevant. Bill?
Hey, this is another educational question. I'm going to guess 5+ years ago, PBS Nova ran a special where they primarily started the first half by saying that amputation technology and amputation methodologies were basically from the Civil War era, and that in the new methods that were being proposed at that time, there was a way to do the tendons and the way to do the things so that these devices would be very effectual, and they had a really high rate of new devices. Did that technology and did that methodology ever make it into the mainstream on how to do amputations very, very differently so that these things would be of real benefit?
Yes, that is evolving. So if a limb has to be removed, if we can plan ahead and preserve the nerve ends and things like that, again, this would be under the construct of computer human body interface, right? So we can do some of that now. So there's examples of basically plugging to the specific nerve. So instead of using body motion, you're basically, if we can get you to think like you want to move that limb as if it's there, then the signal will transmit across that interface to the device, and the device will mimic it.
A large part of it was how to rehook the tendons, because tendons were, again, defined in this special as one has to extend and one has to pull, and so they work together and gives false, when you have an amputation that's just done the crude way, it gives false pain, false all kinds of things. And then they realized that doing this not only helped with these devices, but also eliminated a lot of these false signals that the brain was getting by doing the tendons correctly. Just FYI, that's the way I remember it.
Yeah, that's cool. I know nerve interface is real. I'm curious if they've figured a way to do the tendon to interface to a mechanical device.
Yeah,
that'd be interesting. So again, the exoskeleton, it's on the CMS side for Medicare. So eventually, over time, we can see the relevance and coverage as the devices become more understood, more routine, and more stable in terms of utility. Next slide. So the near-term reality is the following, right? At the employer side, there's still limited awareness. It's not normally covered on the commercial side, and it's only going to be through a member who is aware of it and raises the question of whether this should be an eligible coverage that comes to the forefront, that it becomes something to review, discuss, and consider. On the provider side, most of these are highly specialized applications. They're either limited to very specific specialists and or specific subpopulation of patients. So most physicians aren't even fully clear about the utility and use cases of these. As many examples, physician adoption tends to be slow. They say, up to 15 years, unless there's coverage and reimbursement is involved, and then we find it goes faster. So some of that will be dependent on coverage policies. On the carrier payer side, right now it's most of these that I covered would be considered experimental investigational because they came out of the research space. So even though if they are FDA approved, they may or may not fully be covered, and it will be sort of following experience and coverage on the Medicare side. So CMS typically will go first, and we'll learn from that, and as it becomes sort of more expected and standardized, then we may see coverage roll over into the commercial side. Okay, let's go into the onomics section. So again, this is a catchphrase for all these various omics substances that we are now able to test for and quantify. So I'll go from the top to bottom because biologically, that's sort of the sequencing. So genomics is really around studying and knowing what the DNA structure and genetics are for certain conditions and diseases and being able to assess those. Epigenomics looks at those things that influence. So if gene determines what proteins are produced, the epigenomics kind of determines how they're regulated. How do those productions of those proteins take place? Transcriptomics is focused on the RNA. So DNA translates to RNA, which is the next step that leads to the protein productions. So the RNA expression and activities can be analyzed and assessed. And broadly, that's called transcriptomics. Proteomics is looking at the proteins that come out of the genetic coding. So assessing and analyzing the protein outputs and their structure and functionality. And then the last one is metabolomics, which looks at the molecules and metabolic processes that is the end result. So this is kind of the sequence of from gene to the metabolites and metabolism that ultimately leads to the things that we can do or see and feel. So all these can be analyzed at some level. Obviously, not everything can be analyzed and assessed. But what that means from a health plan is there's more and more tests that become available. And then the question is, what tests are necessary for care versus what tests are just part of research that we inform ourselves and become more knowledgeable. So typically, these kinds of tests have complex and continuously evolving coverage policies. It's more than I can keep track of, and there's a reference database that I look up because these tests are never static and continuously evolve. But again, these are typically within the realm of very specialized physicians and for specific conditions and treatment that become relevant. So as a primary care physician, for example, most of these would not be something that I would be the appropriate person to be ordering and driving prescribing. But again, more and more of these tests become capable, and we'll have to track that. Okay, the next slide is around genetic tests. In the genetic test context that I'm speaking to here are not what the genetic tests, like from the previous page on genomics, that a physician would be ordering because of a need around diagnosis treatment. These are tests that our vendors are now reaching out to employers. So basically direct to employers, making it available through the employers for their employees and members. Their proposition is, instead of waiting till you have a disease to have some of these tests may be useful to have and have the information done in advance. But some of the things that we're testing are rare or less common. So there is the risk of testing and just having a lot of negative results. That's challenge number one. If the test was low cost, probably we could overlook it, but some of these are expensive tests. The other challenge is there's, like any test, there's false positives and false negatives that we have to account for. So it's one of those things, if we look for something and we get a result back, I don't feel symptoms, I don't think I'm sick, but now I have a piece of data that becomes something that I have to, as a physician, need to address or figure out. So here are the set of sort of tests that are now being offered through employers. I'm often trying to explain these tests and the pros and cons and the risk and benefits of these tests. So they include genetic carrier testing, right? So just knowing whether you have a trait, even though you don't have the disease, but you have the trait, and that trait may be passed along to your child. So typically these would be things that could be tested as part of your maternity care. But what this is being offered is move it up front and say, outside of the context of maternity, is it important to know that you're a carrier? Possibly. But then the question is, do you want to know? And if you knew, what would you do about it? So those are the challenges. Early cancer detection, that's the one that you've probably heard of, GRAIL, right? That's basically now using blood. We can try to look for up to 50 cancers, whether you have DNA from cancer. So as cancer cells die, just like our cells, their DNA ends up leaking into your circulation. And this test basically will look for those DNA from cancers in your blood. They cost about $1,000 a test. And again, they don't replace screening, but they can look for other cancers that we don't have any other ways of checking. Pharmacogenomics is looking at genes that influence how your body processes certain medications. So sometimes that can be helpful for that. An emerging area is GI microbiome. So in our stomach, we have a lot of bacteria. Some are healthy and productive, and some are not as productive and advantageous. And sometimes how we feel, how our autoimmune disease, metabolic conditions is doing, it can be influenced by GI microbiome. So now we're able to do more testing on that. We probably have more information and data than we know what to do about, because as you can imagine, there are a million different microorganisms in our stomach. So it's a population of many things that we don't fully understand yet, but we can now start testing for. So that's a quick run through on this. Any one area you want me to go into more depth? Yes, Bill?
A curiosity question. We seem to get a lot of data on the news anyways to testing genes in the basically community wastewater systems to see if a disease is prevalent in a community, and how should we be responding or looking at that, or is that still new?
Yeah, I think with COVID, we discovered, or we've learned that it can be highly informative what we can detect in wastewater, and as a sort of a sentinel indicator of what's happening in the community that wastewater is collecting. So it is infectious disease, but potentially other things like pre-existing sort of factors and traits. Now, the hard part is it's population level, right? So when it comes to infectious disease, we act at the population level. When you're getting to very specific disease and conditions, it's like, okay, but who has this, and what can we do about it? That becomes a challenge. But definitely a lot of things are in the wastewater that can be analyzed.
I think Jessica has her hand up. I'm not sure who Jessica is that? Sorry, my screen is a little funky right now. Jessica, are you there?
Unmute. Okay, sorry, I was looking for the unmute button. Thank you for your patience there. I just had there's such an incredibly knowledgeable audience here, and I was wanting to pose a question with the GI microbiome studies. I felt like there was a lot of excitement there for a while, where they were finding that individuals who were struggling with weight loss, there was some evidence that our microbiome kind of really plays into our ability for weight loss. And they were doing all kinds of different experiments when they were basically feeding people's contents with the biomes of people who just seem to naturally be very thin and skinny. And the reason I bring that up is because it seems like there's been that new emphasis on the shot that people with diabetes were having. It almost seems to have just like completely eliminated that conversation with the studies that were happening early on. And I'm just curious what, like, if you guys know kind of where the medical community is on that. Have they abandoned it, or is it something still, they're looking into, or?
The GI microbiome is a continuous evolving area of interest. because the more we are spending time researching it, we are finding that it has tentacles into many things. If you think about, there's only one avenue for foreign substances to enter our body, and that's through the mouth primarily, right? And the two main substances are food and medication. And each of them can have dramatic impact, near term and long term, on the gut. And to the extent that it can impact cardiometabolic conditions. So to your point around how food is processed and how we metabolize, leading to glucose resistance, obesity, overweight, that's a factor. Autoimmune conditions, and even cancer, and even allergies. So all those are now understood that the microbiome plays a role, because with those two ingredients that we take in, how it's processed and what we get out of it is heavily determined by the microbiome.
And just to add to that, I guess the other entry point was just the delivery of birth, like cesarean versus vaginal deliveries. So I just thought, I was like really excited about that. And then it just feels like that shot took all of its thunder.
Yeah.
Forget what it's called, but thank you.
And not to gross this group out, but for some individuals where the microbiome is so skewed, there is now research and the concept of fecal transplant. So basically taking a healthy person's microbiome through feces, processing it, put in a capsule to basically reseed a person's microbiome to be a healthier mixture. That's something we're looking at.
Oh, so it is still alive and well.
It's
All right, thank you.
Yes. Okay, next slide. And just to show you how busy this ecosystem is from a vendor landscape, these are the main players, not all, but the main players that are sort of trying to bring it to the front line, so to speak, through employers and making it available, whether it's pharmacogenomic testing, cancer, early identification, genetic trait analysis, and obviously at OEB we have Gabby helping with risk assessments. So this one's more around non-genetic based testing on the front end, but risk assessment leading to genetic testing as necessary. So very busy space. Not saying that all this is relevant and appropriate, but it's definitely an evolving space that will become more mainstream over time. Okay, so with all the onomics, if we really push the envelope, next slide, people start to ask, well, what else can we test? Yes, Glenn?
Yeah, I'm sorry. Have there been any studies that have shown, especially with the genetic testing, that a lot of this early testing that has gone beyond kind of what we used to have has led to more treatments being done and higher costs related to that?
Yeah, so if you go back to the last slide, Rose. So if we think about 23andMe as being the consumer grade genetic testing, right? It looked for anything that it could measure, aversion to cilantro as an example, right? Informational, but okay, nice to know. When we get to more of the illness focused tests or capability, the slide before this, Rose, some things are worth knowing earlier on. However, those individuals that need to know it is not the entire population, right? So if there's some reason because of family history that makes the genetic carrier information useful sooner rather than later, then yes, that test can be highly informative and it could lead to appropriate decisions, right? Whether an offspring will want to conceive or not, as an example, rather than wait till the individual has conceived and then you're doing genetic testing and then you realize there's a risk that offspring will be a carrier. So the tricky piece is the vendors would like this to be sort of everybody, made available to everybody. But epidemiologically, it's probably not everybody needs it or benefits. So there'll be a lot of just negative, right? You weren't at risk before, and the test confirmed that you're not a carrier. Other things like early cancer detection. So that is one where we have some statistics. So for every 200 people that get tested, 2 people will have a positive test result. That's going to lead to, so think of it this, it means we saw possibly cancer DNA, but I don't know if you have cancer and I don't know where that cancer is. So now we do have to investigate these 2 individuals. And statistically, only one of them will end up being a true positive. So that means that one of those 2 people will go through unnecessary additional tests to make sure that they didn't have cancer. So that is one of the downside and the risk, yes. Because we're obligated to act on that information now that we have that information.
Is that also the case I'm sorry, not to go back, when you talked about AI and AI picking up, say an oncologist gets an x-ray back and the AI says, well, we got this really small, which is great that they can, the AI can look at this, but has that the potential to lead to, okay, well, the patient saying, or even, maybe the oncologist saying, well, let's take care of that right now at his state, or as you said, other tests that need to be done to rule it out, so to speak.
Yeah. Clinically, I find imaging hard because, again, they're shades of gray. And when they're that small, there's no other feature that allows me to even guess whether this is possibly malignant or benign. And the only way to know that is to take it out and examine it microscopically.
Sure, do a biopsy.
So it creates a clinical conundrum. That's what we call it incidentaloma, because it may be something that we now are aware of, but the reality is it's something now I have to track over time. So my inclination may be, let's check it again in 6 months. If it's changing, then it's active, and active implies that it's something I need to act on. If it doesn't change, I may just continue to sit on it over time, but it becomes something that now I have to address. With early cancer detection, there's a trade-off. When I speak to the oncologists, they're excited that we can detect cancer early, because unless we find cancer early, we can't research how to treat it. But currently, many cancers, if we detect it early, we're still going to wait and observe, because we've never studied cancer at early stages, so we don't have any treatment protocols for it.
Okay. Thank you.
So there's a psychological cost to that as well, right? So now that I know I have cancer, but we don't know how to treat it, and we're still going to just observe it as opposed to waiting, is it better to know and then act proactively, or be sort of ambivalent and wait until it becomes something that manifests?
It will be interesting to see how a lot of like the AI and other things will change if they do, or how it's addressed by the professional associations in their treatment and evidence-based guidelines.
And with more cases and real world data, the AI will process that and analyze that to start to hopefully guide and say, well, for these patients, this is when testing is worthwhile. Instead of just saying, well, if you're 50 and older, you're in the sort of higher risk of cancer category, and that's when we should test. But we can fine tune it to be, well, if you're this ethnic background, previous history, exposure to, smelting chemicals or whatever, then you need to have these tests. Then it becomes more precise.
Sure.
Okay.
Thank you.
Rose, 2 slides, please. 2 slides forward. So on the most leading edge, if we can test various anomics, then the question becomes, what specimens can we analyze? So this is just one example. This is purely in the research realm, where we're finding that within earwax, it's collecting byproducts through your ear canal that we can detect some possible conditions underlying, within the specimen. So again, this is pure research area, but again, if we can analyze various anomics, then finding the specimens that yield the most information becomes the next pursuit. Okay, so the current reality, next slide, is the following. At the employer level, I do get questions about should we be offering these, and these are all sort of additional programs offered through the employer, paid by the employer typically, and a direct-to-employer model. The only clients that sort of seem prone to kind of give it a go, either as a pilot or offering it to their employees, are those that are in very tech-oriented, competitive markets like IT, pharma, and only very few. Literally, I think I can count my clients on one hand that have taken up, for example, the multi-cancer early detection tests. On the provider side, even though these tests are available as part of the care and can be covered within the plan, pending coverage policies and things like that, it's limited and inconsistent because of the novelty and uniqueness of these tests. So outside of specialized clinicians and very specific conditions and diagnosis, most physicians are probably not fully equipped to know when to apply some of these types of specialized tests. On the carrier payer side, it's continuously evolving. The coverage policy continues to evolve as our knowledge expands. So, one test that may not be covered last year may all of a sudden be covered as our knowledge and real world experience and research improves and evolves. But most of these typically have some coverage policy authorization for very specific, well-established use cases. Okay, so now let's kind of go beyond technology and think sort of outside of the box. Next slide. So if we think innovation can be inclusive of something that is highly effective and leads to a high impact, the things that we have been addressing under cardiometabolic health is something that impacts so many other conditions, and some of them are listed on the left here. The same underlying things of concern, like blood pressure, glucose control, cholesterol, weight, BMI, nutrition intake, micro and macronutrients, optimizing that impacts everything from heart disease, cardiovascular conditions, kidney disease, liver disease, autoimmune, cancer, infertility, and mental health. So what's interesting is, what Massachusetts General has defined under brain care is the exact same set of outcomes that we've been trying to drive through cardiometabolic health, focusing on weight, diabetes, and cardiovascular conditions. So that's where the biggest bang ultimately is. And, if we can optimize a few things and do it more consistently, supporting our educators and associates, that it's going to be hugely impactful systemically at the population level. So if you tease this all down, next slide. And I know we look at point solutions as targeting specific things, but I've come to believe that really it comes down to 4 key pillars. That is the root to everything else. And I'm trying to expand the thinking. So we focus on diet and nutrition, but ultimately it's a broader construct of GI health, right? Including microbiome. How can we optimize our microbiome by ingesting things that are more favorable to keeping that microbiome healthy? Instead of just saying, well, you need a minimum of 150 minutes of moderate exercise, it is overall, how do we keep the whole musculoskeletal system healthy, which is inclusive of exercise, but it's also mobility, balance, coordination, everything else. mental health, not just the presence of diseases, but it's also mental resilience, and sleep quality and quantity. So all four things are so key to so many conditions. Our educators and associates supported? Do they have resources that help them optimize each of these four pillars? I think there's always room for improvement. And if we use this as a framework, it's a way to sort of see if we are ensuring the four core pillars are effectively addressed. And I appreciate the question around GI. The next slide is just basically, the GI health is so relevant in so many ways. Cancer screening is front and center. We don't have a whole lot of available options when it comes to cancer prevention, although what we choose to eat and kind of the choices we make in terms of other behavior like smoking and alcohol consumption have a huge impact on cancer risk. So, the favorable food choices that are positive for cancer is really, and this is just a focused list example. These food ingredients are favorable to cancer. And then on the right side are the things that are negatively impactful on cancer. Some things are obvious, obviously smoking, but UPFs, ultra processed food, is in a way carcinogenic. It is not healthy and stuff. And now we have the challenge, it's not just microplastic, it's nanoplastic. It's estimated that each of us probably have a deposit of about 7 grams of nanoplastic within our bodies now, just because of how pervasive plastic is. So, yeah. So a lot of things that are outside of medical care, if we optimize a few things in terms of the things that we should be doing and avoiding those that we don't, at a population level can be hugely impactful. So it's not innovative as a concept. What would be innovative is the ability to adopt and implement it across a population in a highly effective way. Next slide. So UPFs have come up in many circles because I think the awareness of its negative impact and the way it influences so many other health factors and diseases and conditions is now undeniable. That it's worth calling that out. That and I'm not saying don't have any. I think it's like most things, eat the healthy things in abundance and the unhealthy things in moderation. But less is best when it comes to UPFs. And here are the examples of all the cardiovascular factors that it has a negative impact on. Solving it is challenging because UPF is so ubiquitous. It's present everywhere, from Casey's, 7-Elevens to your local grocery store. It's well advertised and it's cheap relative to healthy food. So it's not an easy thing to divert our population. Okay, next slide. So one of the challenges with prevention, so we talked about cancer prevention and screening.
Dr. Schwank, can I interrupt you for a second?
Yes.
We're getting to the care outside the United States. Is that the section we're going to start right now?
Yes.
Can we take a break until 10:20?
Sure.
All right, let's take a pause let's restart at 10:20, okay? Quick bio break. Thanks, everybody. See you in 11 minutes. Are you claiming that Oregon is a center for medical tourism?
Could be if you want to make it.
Big money. All right, I'm thinking everybody should be back. Let's go ahead and roll back into it.
Okay, thank you, Bill. Yeah, so let me close off with more something to stimulate up, to be a little provocative, right? So prevention and screening we feel is so important because it's our best chance of identifying risk and possibly catching illnesses or diseases before they're significant, while they're treatable and less costly. However, even prevention can be costly for the members. So I'm just throwing something just for a math exercise, right? Because it is a math problem because of our system. So if we looked at the cost of airline flight from PDX to Seoul, Korea, hotel stay for 4 nights, 3 days to basically do a concierge level preventative evaluation package. So these are 2 examples for 2 different age groups. Young population that typically doesn't get screened, midlife 35 to 50, and then there's 45 and above. Pretty comprehensive, positive experience, highly efficient process because this whole care model is designed for efficiency and experience. It would still be total cost less than what a plan cost would be to have these same set of tests done in Portland, Oregon. So that's the conundrum, right? So not saying that this is a viable option, but I'm just saying mathematically it has an appeal. Now, within our health system, can we create an experience that is member-centered, that is focused on helping them do what they need to do in a highly efficient way? It's possible because we do it for executive physicals. It all comes down to whether there's sort of a viable model that makes sense for stakeholders as well as the member experience. But this is the challenge I have out there. So is it fully innovative? No, but it's just thinking differently and looking at another region in this world where they've chosen to do this and they market it to other countries and other visitors, and the math actually is doable. Now, HSA can pay for these, is eligible for reimbursing these. So that's the good news, but not the travel. So I'll pause there, open up to questions. Hopefully there was plenty of thought-provoking ideas of what's going on and what could be possible if we were able to think outside the box.
Well, the question is, how do we do these kind of full body preventive screening here, even though we have the same equipment, right? How do we do that as an outpatient service and get the cost, somewhat close, even less than double, I would say, right?
Yeah.
There are resources, certainly in Portland, that can do services like this for younger, healthier people, where they'll do the full body scan and lab work and full screening. And I don't think, I mean, it's probably, I don't know exactly how much it costs. I know it's probably more than $890, but not exceedingly more. And I think anytime medical tourism is brought up, I think you have to be really careful about what we're doing and what we're thinking of doing by sending people abroad. For prevention and wellness, it's probably less, I guess I would say, risky, but medical tourism is a really big deal, and it's a really big problem. It's about a million people a year travel abroad for a variety of things. About 55% of it is actually dental, probably for veneers or implants or things that would be significantly cheaper than here in the United States. But the cost is certainly a driver for that, why people go. Some of the big procedures they go for, cosmetic procedures are a huge one, fertility, orthopedics, transplants even, and bariatrics. So they are the big ones that people go for. But I would say the biggest issue with medical tourism, just in general, if I can just talk for a minute about it, is it's kind of like buyer beware. Because if you go abroad for something, which we don't cover, I don't think any carriers cover procedures that take place outside of the purview of the United States, where we can monitor credentialing of the providers, quality of the providers who are giving this care. I think the biggest problem are complications, and I certainly saw that when I was in practice. People would go abroad for cosmetic procedures, and then they come back to the United States 2 weeks later. Everything was great while they were there, and then they come back with massive roaring infections and complications, dehiscence of their wounds, and then they show up in a provider's office here. And most providers want to take care of their own complications. They're not really looking to take care of complications from someone someone else who did the procedure, let alone someone else who did the procedure in a foreign country where there's absolutely no guarantee of getting the medical records and all of those things. So I just think for prevention and wellness, I think this is actually probably the least risky way, because they're just getting diagnostic exams. They're not having anything invasive done. But I think just in general, the whole topic, I think we should be very careful about how we approach it. And I'm from MODA, by the way.
Thanks, Yale. Okay, let me pass it to Nikki.
All right, next up, we'll talk through the evolving pharmacy landscape with focus on trends and innovation in pharmacy. Next slide. Thank you. In recent months, the FDA has introduced several significant changes that may potentially impact the processes by which drugs can be reviewed and approved. And while all of these are currently within either a pilot program or draft guidance form, the overall focus appears to be in accelerating development and approval of not only new drug therapies, but also biosimilars, as well as individualized therapies such as genome editing treatments. Now on the left there, we have the first program to discuss, which is a pilot program known as the Commissioner's National Priority Voucher Program. And essentially, it aims to accelerate the review process for drugs that align with national health priorities. And those national health priorities are listed below within the slide. The key thing to note as part of this is the drug review time is significantly reduced. So whereas you'll see a standard drug review time at around 10 to 12 months, via this program, it actually reduces it down to 1 to 2 months. And interestingly enough, we've actually seen several new drugs already approved via this pilot program. A couple examples would be the new oral GLP-1 therapies such as oral Wegovy, as well as Foundayo. And interestingly enough, there was a gene therapy approved via this pathway that we'll talk about later. So separately from new drugs, the FDA also recently announced recent action to accelerate development of biosimilar medications. Now, as part of the draft guidance that was announced, the FDA is proposing several updates here noted below, including removal of comparative efficacy study requirements for approval of certain biosimilars and shifting to rely on the analytical testing to identify product differences, as well as removal of switching study requirements, which are used to demonstrate interchangeability with the brand innovator reference product. Again, this is just right now in overall draft guidance. However, finalized guidance is expected to be issued in coming months. And we'll talk more about biosimilars on the following slide. And the last recent change that's been announced is what's known as the plausible mechanism framework. And essentially this aims to facilitate the development and approval of bespoke individualized therapies in situations where randomized clinical trials are not feasible. And this generally occurs in extremely rare conditions. This is where you tend to see this. This framework focuses on treatments targeting specific genetic or molecular causes, such as gene editing therapy. And instead of large trials, approval is actually based on strong scientific evidence, understanding of how the therapy works, and then, of course, supported by detailed patient data. The specifics of it there are noted on the slide. So overall, I would say significant shifts that are being explored within the overall FDA review and approval process here. Next slide. All right, so as we just discussed, the FDA initiative to streamline development and approval of biosimilars, there is the potential to see an influx of biosimilars coming to market in the coming years as these brand products lose market exclusivity. So as a reminder, biosimilars are biologic products that are highly similar to another biologic drug that is already FDA approved. It's known as a reference product. And based on how biologic drugs are derived, an exact copy is not able to be produced by different manufacturers, which is why you see these called biosimilars instead of generics. So while you do see biosimilars for non-specialty drugs, a large amount of biosimilars are focused on specialty drug products, which are very expensive and often are key drivers of planned spend. So as we look ahead towards the next 18 months, there are several biosimilars expected to launch that are also for specialty drugs. And those are listed there within the table below. One thing to call out, you will see that these are approved, but there are varying projected launch dates, and these vary largely based on when the brand reference product is expected to lose market exclusivity. And then you also have patent litigation as well that occurs within here. A couple key ones just to call out here would be Xolair. It's a product that's used for treatment of asthma, food allergies, just to give you an example. And overall, this product works by binding to, it's called IgE, that triggers histamine release involved in allergic responses here. Simponi and Enbrel are both used in inflammatory conditions. And the last one to note there is Perjeta. And this product is used for treatment of HER2-positive breast cancer. And essentially it binds to the HER2 receptors inhibiting cancer cell growth. So a lot of growth here within the biosimilar space, not only this year, but also in years looking ahead as well. Next slide. So as we just referenced development of biosimilars for existing specialty drug products, there are also new specialty drugs on the horizon here. And several examples here detailed below. I'll highlight a few of them. The first product up there the first to call out is known as bulevirtide, and this was actually just FDA approved and is the first targeted therapy specifically approved for chronic hepatitis D infection. And as background, hepatitis D is an infection that occurs in people that are already infected with hepatitis B. And this drug essentially acts as a viral entry inhibitor and binds to and inactivates receptors on the liver cell so that the virus is not able to enter in the liver cells. So basically, by blocking this entry, the drug prevents the virus from not only infecting new liver cells, but also reducing viral spread and decreasing inflammation. Additionally, prior to FDA approval, the only potential treatment was use of interferon for off-label treatment for this. And the other novel therapy to call out is the one at the bottom, which is known as molgramostim. And this is a product used for treatment of autoimmune pulmonary alveolar proteinosis. And essentially, this is a condition in which the immune system mistakenly attacks cells that help to keep the sacs in the lung clear. Current treatment for this is largely around supportive care and whole lung lavage, which essentially clears out the substance in the lungs that's blocking things. But overall, no current drug therapy that's actually targeting the cause here. Next slide.
I'm sorry, can I ask a question?
Sure, of course.
And the cost that's listed there, is that per patient?
Can you go up there? Can you go back to the prior slide there? That's the estimated annual cost in thousands. So based on the overall expected therapy.
Is that per patient or for what?
I believe so.
Thank you.
Okay. And gene and cell therapy. So gene therapies are products which replace missing or faulty genes. Cell therapies are products which modify cell function, allowing cells to respond to a disease. Generally, gene therapies are utilized for rare genetic conditions, while cell therapies are primarily utilized for cancers. And there have been several recent new gene therapies that have been approved, which are outlined on the next slide. So these products here are gene therapies that have just recently been improved here within the last 6 months and are used for treatment of more rare conditions. The first one on the left is Kresladi, and it's the first gene therapy approved for treatment of severe leukocyte adhesion deficiency type 1 disorder, which causes mutations, or excuse me, due to mutations in the ITGB2 gene, which essentially prevents white blood cells from fighting infections. It is an extremely rare condition that affects about 1 in 1 million children globally. And without gene therapy, treatment consists of hematopoietic stem cell transplant or therapies to help fight the infections. Essentially, it's a one-time gene therapy made from the patient's own hematopoietic stem cells, which are genetically modified to introduce functional copies of the ITGB2 gene. Now on the right, it outlines the first gene therapy to treat hearing loss due to variants in what's known as the OTOF gene. And this condition, again, is extremely rare. It only affects about 50 newborns per year in the US. And it uses an adeno-associated virus vector to deliver a working copy of the gene to the cochlea. It's administered as a single infusion, and interestingly enough, will be made available by the manufacturer at no drug cost to eligible patients in the US. One thing to call out, though, is that does not include the administration expenses, so that portion will not be covered. It's strictly the drug cost. And this one on the right here, that is the one that actually was approved via that new pathway that accelerates approval based on alignment with national health priorities that I called out earlier. Next slide. So this next slide focuses on the overall gene and cell therapy pipeline with several new therapies here within that pipeline. And that first product there is called the deramiocel. And essentially it's a cell therapy for Duchenne's muscular dystrophy cardiomyopathy. So there are already products that are on the market for that Duchenne's muscular dystrophy, but this one is focused specifically on the cardiomyopathy. And just as background, Duchenne's muscular dystrophy, it's a genetic disorder that causes progressive muscle weakness, including affecting the heart muscle. And it's often a leading cause of mortality in these patients. This drug works actually by creating an environment that supports overall cardiac muscle repair. It's administered by IV injection every 3 months. And just to give you an idea of where kind of the current therapy mainstay is, it's largely around drugs known as like ACE inhibitors, which are used to slow the myocardial fibrosis projection. Another one to call out there would be the second agent there, which is the paraglashtin. And this is a gene therapy that's used to treat the glycogen storage disease. And it works by delivering a functional copy of the gene directly to the liver via viral vector. And this condition, it's a rare metabolic condition which affects how the body stores and breaks down glycogen. This particular product is administered as a single IV infusion. Current treatment is largely focused on dietary interventions in managing hypoglycemia. The next one to call out there on the list is that sonpiratogen. And this is a gene therapy for advanced retinitis pigmentosa, which I believe we discussed earlier. And this is a genetic disorder that essentially leads to progressive vision loss. This drug works by delivering a gene that encodes for a light-sensitive protein into the retinal cells and essentially allows them to respond to light and restore some of that visual function. Overall, current therapy right now is largely with assistive technologies such as low vision aids and nutritional supplementations. There's currently no cure for this. And then the last two there, that product immediately below it it's a gene therapy for Fabry disease that delivers a functional copy of the gene to liver cells to slow or halt the disease progression. And just as background, this condition is a rare inherited storage disorder caused by a deficiency related to an enzyme that leads to buildup within cells. There is another therapy that is on the market for treatment of this condition, known as Galafold there, that's highlighted there below. And then the last condition is a cell therapy for treatment of chronic heart failure associated with reduced ejection fraction. This product essentially works to help stimulate new blood vessel growth, reduce inflammation, and reduce that scar tissue buildup. Overall, it demonstrated pretty significant results in clinical trials, including a 60% reduction in cardiovascular related death, as well as heart attack and stroke. Next slide.
A quick question on that slide.
Yeah.
Where we have these rare conditions and there's no alternative therapies, drugs that are in like stage 3 trials, what is the minimum efficacy? Not minimum, but what is the typical minimum efficacy where it's like, okay, because there's no alternative for this problem, even though it's rare?
I'm not sure on that. Sarah, are you aware? Or Dr. Chuang?
I mean, in terms of what the FDA is looking for, generally they're just looking for better than placebo.
Really? So 0 plus 1, right?
0 plus something, right? And sometimes with these, it can be challenging as far as how you're defining, like, yes, it can be statistically significant in terms of efficacy, but is it clinically significant sometimes can be in question. Now, a lot of these newer gene therapies do seem to show a lot of promise, but I wouldn't say that's universal. There was the gene therapy for Duchenne's muscular dystrophy that was marketed really widely. I think there was a lot of utilization, but it turned out the efficacy is questionable in a lot of populations. And then it seems like there may be some adverse effects that are coming out now too, like tumors due to the virus vector that was used. I read something about that a couple of weeks ago. So it's a long answer to your question, but it's still evolving. It has to be better than nothing.
But the process, just for my education as well, is that this gives them a label. Like once they get that FDA approval, they get a label, and then we have to deal with it as a drug with a label for specific conditions under certain whatever applications. Is my understanding correct?
Once it's FDA approved for that condition, then it's available on the market. Technically, once it's on the market, the prescriber can cover it or can prescribe it for any purpose. They can prescribe it off label.
I agree.
Most medical carriers will limit to the FDA label.
For our coverage, we limit to the label, and if a new drug gets a label, then we have to deal with it. Is that my understanding correct?
That's typically deferred to the carriers, and so if a drug gets a new label, it may be covered for that new indication, or it may not. If there's other treatments and other drugs, it might not be the preferred formulary agent.
So that's in our formulary, the way we set up our formulary, whether we're going to choose to use a drug, even if it has a label, right?
It's the choice of your carriers. It's the choice of your medical carriers. You're deferring to them. Yes.
And prior authorization criteria, all of that comes into play with it.
Got it. Thanks.
Okay, next up we have innovation within the GLP-1 landscape. In this slide just does a comparison of two new GLP-1 products, both CagriSema and rituximab. Both of them, neither one of them is currently FDA approved. That one on the left, the CagriSema, is currently pending FDA approval. And both of these products are getting a lot of press. So wanted just to talk through overall the differences between the two products. So that CagriSema, why it's receiving a lot of press is it's a brand new GLP-1 combination product. It's rather unique. It consists of a combination of a GLP-1 agonist as well as what's known as an amylin analog. So a brand new combination that's currently not available. And as I mentioned, it's currently pending FDA approval for weight management. However, it is being investigated for treatment of type 2 diabetes as well. Interestingly enough, there was a head-to-head study completed, the REDEFINE 4 trial, which evaluated CagriSema up against Zepbound in a head-to-head trial. CagriSema was found to be inferior to Zepbound in the overall weight loss seen within the trial. In fact, at 84 weeks, CagriSema was associated with about a 23% weight loss as compared to Zepbound, which was closer to right around 25%. So overall results then outlined there, the REDEFINE 4 trial results. Now, the one on the right is the one that's really been making headlines more recently, and this is because it is a triple hormone receptor agonist that's being investigated for multiple different usages, including type 2 diabetes, knee osteoarthritis, liver dysfunction, as well as weight management. And this product is unique because it acts as an agonist on 3 different receptors, including not only the GLP-1, but also the GIP and the glucagon receptors. If this product is submitted and approved by the FDA, this would be the first product approved that activates all 3 receptors there. Why it's been receiving such significant press is that within trials, it has shown a weight loss of around 28%, which is rather significant. Hi, Bill.
So assumption would be that this innovation is going to drive all the other GLP-1 manufacturers, right? They're going to have to respond to this, right?
You would think, yes. If they ultimately, if it's submitted and approved and you have an overall combination of the 3, I think you certainly could see that kind of triple combination therapy being explored by other manufacturers.
It'll be interesting.
Yes, a lot of innovation within this space here. Any other questions? Okay. And then the last slide just does an overall outline of the GLP-1 landscape, highlighting what products have been approved, what's forecasted for 2026, as well as innovation within the upcoming year. Now, when you focus on 2026, that product there that's highlighted, that's the CagriSema, which is expected to receive a potential FDA decision later this year. As I mentioned, that initial FDA approval is focused on weight management. However, it is, as you can see in that upper right-hand corner, being studied for type 2 diabetes as well. And that retatrutide there is the product that we did just go over. That product has not been submitted yet to the FDA. However, potentially could be within 2027. And then if you go to the next slide, then it's just a continuation again of outlining what's available, potential forecasts for 2026, and then beyond. That middle product there is tirzepatide. So examples would be Mounjaro or Zepbound, and currently potentially indication expansion for CV risk reduction for this product. Any questions on anything that we went over? Yes, Bill.
So when I see that you talk about it, there's a 2 and a 3% difference between the things, and 300 pounds, you're talking like 6 to 9 pounds difference between the average study, and weight loss percentage into pounds. Would it not be more driven by side effects and cost as opposed to I got 6 more potential pounds to go if I'm 300 pounds?
I mean, I think everything comes into play. You have not only the not only the efficacy of these products, but certainly the safety, because for these products to be effective, there's an adherence component to it. But I would say if patients are experiencing significant side effects of it, they're not going to be adherent nor continue the therapy, which is required for the efficacy of it. So I definitely think side effects certainly kind of come into play with the overall long-term effectiveness that is seen within this. And then two, to your point, the overall cost, right? Because these have to be affordable for patients to continue on them.
And that brings me to my next question, which is, are there any new ones that you see here that are less of a rebound effect after you get off of them, or are they all still showing the lifetime usage model, or how does the new stuff look in that aspect?
Mm-hmm. So from what I've seen, it is kind of that chronic use component of continuing for the overall long-term weight management.
Okay, so unless you have a severe lifestyle change, you're going to rebound if you come off this drug, right?
Correct. Yes. And I'll tell you, even with these medications, a lot of them are studied in parallel with the lifestyle modifications as well.
Mm-hmm. Any questions else from the board? This is their last slide. So any other questions from team members? All right, seeing no hands going up, I will thank Mercer for this. Was a lot of great information. As you all know, at Mercer, this is my favorite meeting of the year. This is where I get to see a lot of what's rolling and what you see, besides watching PBS all the time. And this is always intriguing to see what's rolling and what we might have to think about, especially not for this summer, of course, but future summer work groups as we're looking ahead with these kind of things. Some interesting points were definitely brought up, including the AI work that is going to change the way we do healthcare, in my opinion, over time, not tomorrow, but over the next decade or so. I think we'll be hearing a lot of, well, back in my day, this is what we had to do, right? Is coming. I had one other question with regards to AI that's not really AI, which a lot of the drivers for AI in various industries is the lack of workers in that industry, pushing forward the need for more automated things. And what is the outlook for healthcare workers? Are we still declining? I hear a lot of people saying they're going to move into healthcare services because it's where AI might have the least effect, and they're seeing in things like that. What does anybody from Mercer have a comment about healthcare industry employment and worker situation?
Data is evolving. I don't think you can replace the human element, so I think there'll be a lot of augmented AI. However, that being said, many first line medical needs of patients can potentially be serviced through AI, right? So an example would be a mother with a small infant, and it's Sunday evening, and the question that she wants to know is, can this wait till tomorrow morning when I can call the pediatrician? Because the alternative is I'm going to go to the ER. So there was a study just recently that compared sort of diagnostic and triage capability, and it's a mixed bag. But when I look at ChatGPT and how it responds back, there's always a disclaimer that says, this is just based on the information you provided. If you think this is something that is more serious, then seek medical attention right away. So there's a bit of a safety net statement, but for what it guides the individual, it can avoid a lot of the initial triage type of medical needs. Now, you need enough people sort of taking advantage of that, and the initial AI source sufficiently intelligent and reliable to address that need. But I can potentially see in the near future that with enough visibility, consumer acceptance, and access, that can become, or through carriers that offer that as a service, that a lot of that can be offloaded, and then primary care can be focused on more medically intensive care.
The other item that really stands out for me, because I know you've been hearing me talk about it for years, is that ability to look at body fluids from whichever hole they're coming out of, including a stick, a jab, and looking for those proteins or DNA or things, and how that equipment will become cheaper, more accessible lab stuff, and projections on that, just to try and get those earlier detections, and how we will increase our lab capacity to do these kind of things. So again, last chance on anybody from the floor. Anybody want to make a comment or a question?
Bill,
Dr. Laura? Yeah.
Yeah, I just add a comment there so we can share this if you want. And it's also reinforcement, pretty much the prevention that Mercer is sharing with us and thinking outside the box. So I'm really excited to see this moving forward. Thank you.
Yeah, we want to study these and see out for sure. This is very exciting. It's long-term studies, right? It's not the next upcoming renewal studies that we tend to focus a lot of attention, but we still need to keep a portion of SEOW looking at longer-term efficacy, efficiencies, and things that we can do to promote the plans.
So
Okay.
Bill, this is Ann. I will say, just because, with my university, we have both the AI and, engineering, and we have the health and the medical lab science. So I'm excited because now I get to know something they may not. So anyway, thank you.
Excellent. Again, that's why this is my favorite meeting of the year, right? Why I'm always making sure we do this meeting, right? We're going to go on to a most exciting topic, which is looking at SEOW leadership for the next year. Kimberly is stepping off, and I'll turn it over to Glenn on just the format for that, and then we'll talk about who wants to go. And as you know, my hand is always in the air. So,
yeah, Kimberly and Bill, well, currently, as you know, Kimberly Hendricks is the chair for SEOW and Bill is the vice chair. Their term technically ends in September. So we need to elect a new chair and vice chair for the 26-27 year for SEOW. Basically, the chair and vice chair's roles are to for the chair to run the meetings, and then the vice chair, of course, would step in if the chair was not available, such as in this instance. The other issue too that the chair and vice chair participate in is helping to set the work plan for the year with staff and Mercer's assistance, of course, and also prepare for the upcoming meetings. We generally have really kind of by every other week meetings for half an hour on Mondays, but those, of course, can be adjusted if necessary. For this upcoming year, the chair would be selected from the OWEB members on SEOW, and the vice chair would come from the PEB members, because it's the opposite from what we currently have, and it's really kind of written into our charter so that we can rotate and get as wide, participation. So that's kind of just to give everyone an idea of what tasks and responsibilities are. So Bill, I don't know if you want to just kind of open it up to the floor, starting with the chair.
And I'll start. So I'm very happy to be the chair for the next year of SEOW, but also just as happy if anybody else wants to do it from the OWEB side to be a participating member in SEOW. So for the three of us, which is Dr. Laura, Robert, and me, we need to just choose that who wants to nominate for either me or somebody else. Just throw your hat in. And on the other side of PEB, Andrea, sadly, you didn't step back in time, so you're here. So I'd suggest nominating you for the PEB, but you need to self-nominate because that's on your side.
I was going to nominate Kimberly, but she's not
I thought
here.
Kimberly was stepping off, right?
Kimberly is retiring in September. And so.
All right, well, I guess I'll nominate myself for this honor, since I'm the only one
for the vice chair, right? It would be for the vice chair seat. We flip back and forth. But Robert and Dr. Laura, please chime in.
Unless Dr. Laura wants it, I nominate Bill.
Yeah, I agree. I also go with Bill.
Okay, so I think that kind of precludes the vote, since all three members of OWEB have agreed to have me be the chair. And Andrea, you have an issue with me being the chair, right?
Not at all. I would nominate you. Go for it, Bill. Right. You have the tenacity. Okay. I'm happy to have you do that.
And I think everybody is just asking everybody again, Andrea, to be the vice chair. Anybody have any comments from Robert or Dr. Laura? You okay with that?
Yeah.
Yep. Okay, I see thumbs up. All right, we're good. So that takes care of that. Glenn, that was a half an hour done in 3 minutes.
Okay, right. So we
I think that takes us to the end of the agenda. So let me open up the floor for anyone on the call. Please chime in on anything you want to make a public comment on, or whatever. And let me ask Rose first. Rose, did we get any public comment?
No public comment. Okay.
So I'll open the floor up for anyone participating in today's meeting. If you have anything else you want to add before we close out.
Well, I would just mention on a different subject, not on what was discussed, just to let everyone know that we won't be having a July or August SEOW meeting.
Good point. And there is work being done on legislative concepts this summer for replacement of the 3.4 cap. There's a lot of legislators involved. I know I've talked with several, and Glenn and Ali are talking with the governor's office. So if you want to have knowledge of that or keep a post, just reach out to me or Ali and ask your questions. We're both actively involved in what we're going to do. And definitely all the legislators, especially since they're PEB members, are greatly engaged in what's happening here. So so there's some good ideas on the table, and feel free to send me a note if you want to talk about it. With that, I didn't see anybody else's hands go up. So I'll there's something in the chat, but I don't know what it is. Maybe it's Oh, that's from Dr. Laura. Never mind. I got it. Okay, well, we're going to call it. And for us OEB members, we're going to reconvene at 1 o'clock today online. Andrea, have a nice day. And everybody else, see you or see some of you at 1 o'clock. Thanks, everybody.
Bye.
Thanks. Bye.
Thank you.
Thank you, Bill.